It
was like 2 years ago, maybe.
Yes, you're right, for the steroid resistant. So it took 2 years to come back with a new one. Let's see what happens in 2 years' time.
Okay, I think we should start. So good evening, everyone. I'm Eugene from Hong Kong Children's Hospital, and this is my greatest pleasure to host the Ipna Best Clinical Practice webinar tonight. We are very pleased to have Professor Dieter Hafner to present the clinical practice guidelines on steroid-sensitive nephrotic syndrome, which is recently published in the journal Pediatric Nephrology. So Professor Dieter is a professor of pediatrics and head of the Department of Pediatric Kidney, Liver Metabolic Diseases at Hanover Medical School, and is also coordinating the Center for Congenital Kidney Diseases at the Center of Rare Diseases. His main interests include the genetic and mechanistic exploration of rare kidney diseases and CKD-MBD. He is the assistant president of the ESPN. He is also the past chairs of the Ipna Best Practices and Standard Committee, the Ipna Publication Committee, the ESPN CKD-MBD Working Group, and the Guidelines and Pathway Task Force in the Ipna. He has led and been heavily involved in several randomized controlled clinical trials, patient registries, European and international clinical practice guidelines, and he has also published more than 250 original scientific articles, reviews, editorials, and book chapters. So a few housekeeping messages before we start the meeting. The talk will roughly last for 40 minutes, and hopefully we can have like 15 to 20 minutes for the Q&A sessions. So please feel free to leave us any questions and comments throughout this presentation so we can start the Q&A right away. And it's my greatest pleasure today to welcome Dieter. I'm very, very pleased to have the opportunity to moderate the section today. So thank you so much, and the floor is yours.
Thank you very much again for your kind introduction. And just fixing my presentation. Do you see my screen now? Can you see my screen?
Okay, yes, I can see.
So thank you very much. So I'm presenting this this guideline. However, this guideline is the result of work for more than 50 pediatric nephrologists all over the world. So I'm presenting this on behalf of the Ipna Best Practice and Standard Committee and all the core members, which I will mention at the end. I will have a nice picture from them. So first, my disclosures. I have some disclosures, but they have nothing to do with the content of this presentation. And this is the guideline. You don't have to write something today because everything is open access, and you can just assess this via PubMed. Agnes Trautmann is the first author. She was doing a lot of work, and many other people contributed to that. And without one of these, it would not have happened. So thank you very much just at the start of the talk. So what is the rationale for this guideline? Idiopathic nephrotic syndrome is the most frequent pediatric glomerular disease, affecting 1 up to 16 per 100,000 children per year globally. About 90% are steroid sensitive, so it's steroid sensitive nephrotic syndrome that it's all about in the guideline. 70–80% show at least one relapse during follow-up, and 50% of these will experience frequent relapses. So that's the tricky ones. The frequent relapse in nephrotic syndromes, or the worst case scenario, becomes steroid dependent. That's steroid dependent nephrotic syndrome. And I learned when I started my career in the last century that this disease will wean off in adulthood. This is not correct. Now we know that about 10 up to 30% of patients, it depends a little bit on the setting, which hospital you are, continue to show relapses as young adults. So we have to be careful what we do. If we treat patients with medication and they have drug-associated complications and then need also medication as adults, this way it may be very, very tricky. However, Up to date, there's no international evidence-based, systematically developed recommendations on the diagnosis and management of children with steroid-sensitive nephrotic syndrome, except a focus document from KDIGO. So what is it all about? It's steroid sensitive, so we can just give steroids to the patient and everything is fine. But as you can see here, for this child who was just the first episode of nephrotic syndrome, she had really steroid side effects. And that's the case for many other patients. And this is just a table from the Ipna publication where you see the frequency of all these naughty complications of steroids. It's a lot. Hypertension, 10%, ophthalmological disorder, 3%, growth retardation, 8%, psychological disorder, 20%, Cushing with appearance, 40%, infections, 20%, osteoporosis, 0.8%. This is far too much. And this is recorded in patients receiving treatment of 12 to 24 months. So I think we should do it better. However, also other steroid-sparing drugs have some complications like cyclophosphamide, which has gonotoxicity, potentially leukopenia, and also the calcineurin inhibitors, which are very effective, may also have some tricky side effects. For cyclosporin, for example, hypertrichosis, gingival hyperplasia, for tacrolimus, especially in adolescents, obese adolescents, diabetes, and it's just a matter how long you give it. This is a paper from Jutta Gellermann from Berlin, where you can see you just have to give it 5 years, and then you have a drop of 20 ml per minute per 1.73 square meter. So they are very effective, but if you have prolonged exposure, this is a very good center. GFR goes down due to nephrotoxicity. So at the beginning, we sat together and said, what do we want? Well, treat to target. We want to achieve freedom from recurrence, minimize side effect. In Latin, we call it nihil nocere, and we want to improve quality of life. To do so, we use the GRADE method, where we created so-called picker question with certain questions to address. We had a core group. They developed recommendations. They were graded. I will show you the grading system. And then we had an independent expert voting panel. They looked at all our recommendations independently and scored them if they agree or not agreed. And if they were not happy, and if there's an agreement less than 70%, the recommendations came back to the core group, and we had to rewrite them until the recommendations were highly accepted. That's at least 70%. And I'm very happy that in the end, all recommendations had an acceptance rate of more than 90% in the end. This is very important. This is the so-called Delphi method, because then you get a frank feedback from an independent group. And the expert voting panel existed from physicians from all over the world, from all continents, and from all Ipna regional societies. So this is really a global guideline where all people from all continents and countries gave a strong input on this guideline. This is very important because later on the guideline must be actionable. So if a guideline just works in Europe, it's not an international guideline. So it must work on every continent in the world. So that's the grading system. So if there's high evidence and a clear benefit or harm predominates, we can say it's a strong recommendation. If there's only low evidence and if benefit or harm are balanced, then maybe we can't give any recommendation. So in the end, we have the grading system. You will see on each slide the grading, and just as a reminder, if you don't want to look at these letters, if we state something like we recommend, then it's a moderate or strong recommendation. If we state we suggest, then it's always a weak recommendation. So strong, moderate, recommend. Weak is always we suggest. So it's more easy to read. Starting with definitions. So this is quite straightforward. Large proteinuria defined as a urinary protein creatinine ratio above 2 milligram per milligram in the first morning void, or 24-hour urine sample with at least 1 gram per square meter, corresponding to 3+ or 4+ by urine dipstick, in combination with hypoalbuminemia. We defined it as 30 gram per liter Some people say it's 25. We felt that 30 is fine. And we added the term edema in settings where serum albumin levels is not available. This is a global guidelines. In many countries, we will always do serum albumin levels, but in some setting it's not available. I said, well, if albumin is not available, you can go by this definition. And we say, well, this is clearly defined nephrotic syndrome. So first we have to say what's steroid sensitive. And basically, we use the same definition as in the first guideline for steroid-resistant nephrotic syndrome, where we say that we have to quantify the proteinuria ratio, and then we have to look after 4 weeks. And if we get complete remission after 4 weeks, then it's clear, then it's straightforward. However, we know that also some patients will respond after 6 weeks. And this we also call steroid-sensitive nephrotic syndrome late responder. They will later on get the same procedure and treatment as other patients already responding after 4 weeks. And to appreciate for this setting that people may respond late, we created already for the last guideline the term confirmation period. These are the 2 weeks where we can test the further response to corticosteroids. Some people may even give methylprednisolone pulses. We may initiate RAS inhibitors to reduce proteinuria, and of course we need genetic and a real kidney biopsy to see if the patient has a kind of monogenic steroid-resistant nephrotic syndrome. So this is just the basic setting to define steroid-sensitive nephrotic syndrome. And then we need to move forward for the definitions. First, we say, well, we just keep the old definitions. They are fine. There are many wise people made the definitions, but during the process of the guideline, we recognize that sometimes we need to modify old definitions, which was very tough for us. And sometimes we need new definitions. I will guide you through this. First, we said, well, we want to reduce steroid toxicity. To do so, we changed an old definition for infrequent relapsing nephrotic syndrome. We kept that at least less than 2 relapses in 6 months, but we reduced it from 4 down to 3 lapses in any subsequent 12-month period, because we want to avoid high steroid exposure. Because if you say infrequent relapsing nephrotic syndrome, it's not just a definition. This must be a definition which is never ever associated with severe side effects. That's why we reduce the frequency of relapses. And then vice versa, frequent relapses is more than at least 3 relapses in any 12 months. And then steroid dependent, it's still the same definition like it was ever. It's a patient who has experienced 2 consecutive relapses during recommended prednisone therapy for first presentation or relapse, or within 40 days of its discontinuation. Relapse is clear. You have, again, large proteinuria. It's the same definition as the beginning, but here we say on 3 consecutive days with or without reappearance of edema in a child who had previously achieved complete remission. And then we say, well, we need new definitions to define patients who are at risk for steroid side effects. So we said, well, what could be a complicated relapse? When we said, well, a relapse requiring hospitalization due to 1 or more of the following: it's severe edema, symptomatic hypovolemia, or acute kidney injury requiring IV albumin infusions, thrombosis, or severe infections, for example, sepsis, peritonitis, pneumonia, and cellulitis. Please remember this. You will hear it later on when we talk about when to start a patient on steroid-sparing agents. And then sustained remission, we clearly defined. We also need this for later on. No relapses over 12 months with or without therapy. And then we have a new definition. We said, well, when are we happy in the patient on treatment? Well, we call this, if we are happy, we coined the term steroid-sensitive nephrotic syndrome controlled on therapy. Controlled on therapy means infrequent relapsing nephrotic syndrome, you just heard it, or sustained remission, you just see it above, while on immunosuppression in the absence of significant drug-related toxicity. So we want both. We want that the patient don't have relapses, but we don't want to have side effects from the medication. And you see here, it's drug-related toxicity. It's not steroid toxicity. As an example, you have a patient on calcineurin inhibitors, high dose, no relapses, but GFR is going down or severe other side effects happen, then the patient is not controlling therapy, then something is wrong, and then you have to change something in the medication. And then, of course, not control the therapy is the vice versa definition. And then we had the hardest time, but we made it in the end. We had to define stereotoxicity. What do we call stereotoxicity? Means what is significant? When do we have to think about to change something? So new or worsening obesity, overweight, sustained hypertension, hyperglycemia, behavioral psychiatric disorders, sleep disruptions, impaired statural growth defined as a height velocity below the 25th percentile and or a height below the 3rd percentile in a child with normal growth before start of steroid treatment. And then Cushing-Gilliard features, stria rubra, distensia, glaucoma, ocular cataract, bone pain, avascular necrosis. So we felt that these are all red flags when to change something. You can say, well, I don't want to see this anyway. I want to switch earlier, but these are really red flags when we say, well, now it's over steroids. We should get rid of steroids. Diagnostic workup. We have a figure and table. I will guide you through the main diagnostic measures. First of all, we do not recommend a routine kidney biopsy and genetic testing in the initial diagnostic workup of a child with nephrotic syndrome who present with typical features, nephrotic syndrome, and a typical age, that means age above 1 year. We recommend considering genetic testing and or kidney biopsy in infantile onset nephrotic syndrome. Infantile means age between 3 and 12 months. So this is the whole algorithm. I will guide you through that. Maybe we start here. Congenital nephrotic syndrome, we got a nice guideline. If there's features for congenital nephrotic syndrome, we go for the guideline from Lydia Boyer, published in Nature Reviews 2 years ago. So we follow this guideline. If the patient has atypical features, suspecting glomerulonephritis, then you go for kidney biopsy. This is straightforward. If this is not the case and the patient has a typical age between 1 and 12 years, we just go straightforward for prednisolone therapy. If the patient is aged above 12 years, I will show you later on the rationale for that, then you may go for 2 strategies, which are both fine. Straightforward, start prednisolone or performing a kidney biopsy. If a patient has infantile nephrotic syndrome, then it depends a little bit on the availability of diagnostic measures and what you feel may be better for the patient. You may also discuss this with the parents as well. So if you have infantile nephrotic syndrome, some of them really have hereditary causes for that. And if you have genetic testing readily available, you may withhold prednisolone and go straight forward genetic testing. If this is not readily available and you want to start prednisolone, that's fine. That's also a possibility. And some people also want to go for kidney biopsy. They have it readily available. If there's diffuse mesangial sclerosis, looks like a WT1 mutation, then of course you need further genetic testing, and depending on that, treatment with prednisone or you follow the congenital nephrotic syndrome guideline. And if there are other histopathologies, then minimal change in FSGS, they may need specific treatment. And anyway, if it's minimal change or FSGS, you go for prednisone. That's why see many errors go to prednisolone. So many people in the core group felt, well, I go straight for prednisolone. In my center, we are often lucky to get genetic testing very quick. So we rather go for genetic testing, but it really depends on the setting. So 3 possibilities. And then you see after 4 weeks, I just showed you at the beginning, that's why you say define steroid sensitive or steroid resistant, and you use the confirmation period. So I will repeat this a little bit now. So we have to check the relevant patient history. You have to assess how diseased is the patient. And if there are patients from endemic areas, you may search for specific secondary causes of nephrotic syndrome, like sickle cell disease, HIV, hepatitis, malaria, or screening for tuberculosis. So you will know if you're in a region where this is endemic, and then you check. Physical examination, of course, edema, blood pressure, etc. Lymphadenopathy, this goes a little bit also in the direction of lymphoma. So if you have suspicion of lymphoma, you also need a chest x-ray, for example. You have to see if the patient has just a severe infection. This is very important before you start the patient on immunosuppressive. And then, of course, external feature, thorough examination, because these patients usually have syndromic nephrotic syndrome, and they will never ever respond on immunosuppression, and you need genetic testing. Dysmorphic feature, ambitious genitalia, eye abnormalities, rash or arthritis. This is more for glomerulonephritis. And then, of course, you have to check the family history if there are funny diseases around in the family. Proteinuria you check by first morning void urine, and then you check for hematuria. And this is recommended for at least once before starting the treatment. So quantifying of the proteinuria-creatinine ratio is at least once should be done. I know if you're in a low income setting, then it's cost something, but it should be done at least once. You check a blood cell count, GFR, electrolytes, serum albumin. You should check complement and other immune markers in those patients with macroscopic hematuria. I know that many hospitals do this anyway, but we say, well, it's not mandatory. But if there's macroscopic hematuria, you should do that. And then you may consider before start of prednisolone to check for the titers against varicella and MMR. Kidney ultrasound. This was a nice discussion, because I usually have the reflex to make a kidney ultrasound in any patient who comes into the outpatient clinic. But to be honest, it may not be necessary for all patients. So why to do that? We want to exclude kidney malformation and venous thrombosis, and in patients with reduced eGFR, hematuria, abdominal pain, and always before kidney biopsy. And chest X-ray, I just told you, this is recommended in patients with suspected lymphoma. Okay, now we come to the case of age. So now in the KDIGO guideline from last year, it's clearly stated perform kidney biopsy in children with nephrotic syndrome aged above 12 years. Well, when you look at the literature, there's a peak around 5 to 10 years, but later on, the frequency of minimal change just goes down. And you can say, well, 12 years, you can say 15 years or 20 years. So there's no clear cutoff. That's why we say in the new guideline, consider kidney biopsy in patients aged above 12 years of age and on a case-by-case basis. Histopathology, I can skip this because I just told this to you. Genetic testing, I can also skip this because I already told this to you. And now we go to primary immunosuppressive treatment. So if the decision was made to start prednisolone, we recommend that infants aged above 12 months and children or adolescents up to 18 years with the first episode of idiopathic nephrotic syndrome should receive daily prednisone. Either prednisone or prednisolone is exchangeable for 2 protocols which are both working, and there's no evidence that one protocol is better than the other. Basically 4 weeks plus 4 weeks, whereas the 6 weeks plus 6 weeks, and the same dosage, always 60 milligram per square meter or 2 milligram per kilogram, where the maximum dose of 60 milligram, followed by alternate day 40 milligram per square meter or 1.5 milligram per square meter. There are some data that the longer protocol may be better, but there are also some data that the longer protocol may be associated with more stereotoxicity. Both protocols are fine. We recommend not to divide the dose, but rather give single morning dose. There's evidence from randomized trial that it's nicely working, and it's made also better for compliance or adherence of the patients. We do not recommend tapering schedule during alternate day, and we suggest that the dose should be rather calculated on body weight or body surface area. So what you monitor, we recommend that the patients are educated to use urine dipsticks. And if there's a low resource setting, there's also the possibility to use the heat coagulation test. This is outlined in a supplemental material. So Schmitter Banjari made nice PowerPoint presentation on that. You can have a look on that. And then on follow-up, kidney biopsy, well, usually not, but you may do this if there's a change in therapy or to clarify prognosis. And we will say, well, this may be considered especially in patients on prolonged calcineurin exposure, especially with high doses and or with signs of CNI toxicity, such an unexplained decrease in eGFR. However, later on we'll see that we do not recommend prolonged exposure. So you should always avoid this setting. So usually you should not need to perform a biopsy. So if the patients are leaving home, they should do urine deep strip testing until remission. In the first year, this is an expert opinion, we'll say, well, at least twice weekly. However, we know that some patients are more comfortable to do it more often. On the other hand, we do not want to terrify these pure children, and twice weekly may be fine. And if there's any case of signs of relapse, we recommend a daily testing, especially in case of infections. Relapse therapy, that's straightforward. That's a single dose, the same dosage as in the initial period, and until the urine is 3 days negative, and then we used an alternate day protocol for 4 weeks, and we do not recommend tapering the schedule during alternate day dosing. This was clearly discussed also with endocrinologists, and there's no need for that. You just poison your patients if you give prolonged treatment. And then there was a huge discussion because KDIGO recommends to use a daily low-dose prednisolone in patients with upper respiratory tract infections. This is based on 4 small randomized trials, and during our guideline process, a new guideline was coming out, the PREDNOS trial, a large, extremely good powered publication, and this is a forest blog which is done by Elizabeth Hodgson, where she compares the risk ratio for patients on prednisolone compared with placebo, and you see they all cross the line here in the PREDNOS trial, and the trial was showing a benefit of on daily prednisolone has also risk for bias. So we ended up, there's no evidence to give low-dose prednisolone in patients to reduce the risk of relapses during upper respiratory tract infection. So however, we said, well, there may be some patients, this is a D-week expert opinion, who may benefit from such an approach. Okay, so we say, consider a short course of low-dose daily prednisolone at the onset of an upper respiratory tract infection in children who are already taking low-dose alternate day prednisolone and have a history of repeated infection-associated relapses. So these patients are clearly at risk. They are already on alternate day prednisolone, and they may deserve it or may benefit from this approach. Second line therapy, we recommend the use of maintenance therapy in all patients with frequent relapsing or steroid-dependent nephrotic syndrome. And in patients with frequent relapsing nephrotic syndrome, we recommend either the introduction of a steroid-sparing agent, as detailed below, or a low-dose maintenance prednisone given as an alternate day or a daily dose. And then there was the question, which patients deserve the introduction of a steroid-sparing agent? Here we come back to the definitions you just heard 20 minutes before. So the introduction of a steroid-sparing agent is recommended in those children who are not controlled on therapy, that means frequent relapsing or drug toxicity, or who suffer a complicated relapse, or all those who are steroid dependent. That's clear, steroids doesn't make sense if patients are steroid dependent. So this was an easy one. And then we come to the tricky part, which steroid sparing drug should be used. You see here some drug names, and there are different strategies all over the globe. There are different availabilities of drugs. Some drugs are more expensive, and there was no real consensus that one of these drugs should be preferred, because they are more or less each effective. They have different side effect profile, so it should be done more on a case-by-case basis. So we just wrote down this sentence: We recommend that the selection of the steroid-sparing agent be made in conjunction with the patients or guardians in order to choose the most appropriate medication for each individual according to their values and preferences. This requires not only information on the efficacy of these medications, we are very good in that, but also disclosure of possible side effects as listed in Table 5. I will show you this table in a minute, and we will also provide patient information brochures showing all these side effect profiles so that we can really make informed consent how to move on. And then the introduction, we recommend the introduction of one of the following steroid-sparing agent, and this is listed in alphabetical order: calcineurin inhibitors, cyclophosphamide, levomersol, and MMF. You don't see rituximab. We reserve this for later on, and I will show you in a minute for which patients will feel that it's good. First, this is the table number 5. You see all the possible adverse events, and also the costs, so you can discuss it together with the parents, and also depending on the availability in your country, what to give. And then we coming to rituximab. We recommend using rituximab as a steroid-sparing agent in children with frequent relapsing or steroid-dependent nephrotic syndrome who are not controlled on therapy after a course of a treatment with at least one other steroid-sparing agent at adequate dose, especially in case of non-adherence. So we brought it together. So it didn't work on the first steroid-sparing agent, or the patient is non-compliant anyway. And rituximab is given intravenously, so in some adolescent patients it really works nicely if they don't take the other drugs. And in any case, if you have already a steroid-sparing agent, you can also switch to another steroid-sparing agent if the patient is not controlled on therapy. And if you give this steroid-sparing drug, we recommend considering tapering and discontinuation of maintenance treatment in all patients with sustained remission for at least 12 months. So some people keep it up to 2 years, but we recommend considering it at least after 1 year. Okay, now we come to calcineurin inhibitors. We recommend therapeutic drug monitoring. You can read up all the dosages and the trough levels in the guideline for cyclosporin and tacrolimus. I will not go through this today. And we always recommend that the lowest effective CNI dose should be given to maintain patients' control on therapy, and we recommend avoiding prolonged use of CNIs for more than a total of 2 to 3 years. Then we also don't have to biopsy them. That's a nice thing. If CNIs have to be continued, we recommend that a kidney biopsy be considered. That's clear. Cyclophosphamide, we recommend to start this in steroid-induced remission and using either a single course of 12 weeks with 2 milligrams per kilogram, or a single course of 8 weeks with a high dose of 3 milligrams per kilogram with a maximum dose of 150. And the cumulative dose should not exceed 168 milligrams per kilogram because of the gonadotoxicity, which is at least proven in males. And we recommend that if adherence is uncertain, you may use monthly IV cyclophosphamide, giving 6 dosages. It's good to combine cyclophosphamide at the beginning with prednisolone because it takes some weeks until it works. And so this is a D week, and then we just wrote down what the expert feel is a feasible dosage, starting with a dose of 40 milligrams and reducing to 10 milligrams per square meter over the course of treatment. Recommend monitoring of neutropenia, leukopenia, thrombopenia, check this. If it drops down, then you should cease that and restart it. This is rarely the case, but you should monitor that. And then you should, because it could make a blood hemorrhage, patients also advised to have a high fluid intake to ensure high urine output during the treatment. Levomersol, there's a typical dose of 2 to 2.5 milligram kilogram given on alternate days. and after remission was achieved by prednisolone. It's the same like with cyclophosphamide. And then there are some side effects. Well, there's always a matter if it's available. We felt it's good to check for ANCA antibodies, and then we also recommend to check the patients for developing a rash, and to check for the blood cell counts and hepatic transaminase, maybe every 3 to 4 months. MMF, or mycophenolic sodium, the starting dose is 1.2 gram per square meter with a maximal dose of 3 gram divided into 2 oral doses. Alternatively, you can give MPS. The equivalent dose of MPS for 500 milligrams is 360 milligrams. And we also suggest that starting these drugs when the patient is also in remission on alternate days. Therapeutic drug monitoring from MMF. Well, it's good. It's very good, but not every patient needs that. So if a patient has a regular dosage and is controlling therapy, then everything is fine. But you have a patient who is not controlling therapy, has, for example, funny leukopenia stuff, bowel problems, bowel pain, or frequent relapses despite this treatment, you may do this, and there's an abbreviated formula, just 3 samples in 2 hours, and if the area under the curve is above 50, you can be sure that it's a nice drugs exposure. And then it's very important that you clearly explain that sexually active adult female must use adequate contraception if they get MMF or MPS. Rituximab, I just told you before, if the patient are not controlling therapy after a course of at least one other steroid pain agent, and in the case of non-adherence. And then we looked at the literature, and it's clear that it's especially preferable, both in terms of safety and of effectiveness, in children aged above the age of 7 to 9 years. So in very young children, it may not be optimal, this drug. And then it's always the question how often you should use this, and it's recommend the standard dose is 375 milligram per square meter, ranging from 1 to 4 infusions, preferably when the patient is in remission. Otherwise, the fancy drug is just lost in the urine. B-cell monitoring, it's good because we know if the B cells creep up again above 5 cells or above 1% of the cells, then the patient has a higher risk of relapse. So in these patients, you may go for next shot of rituximab. You should check immunoglobulin G levels to detect hypergammaglobulinemia. However, we do not regularly recommend to replace immunoglobulins if the patient has hyperglobulinemia, and only in patients with recurrent infections. And then the regular medication with paracetamol. And then of course, why do we give rituximab? We want to get rid of the other stuff. So we recommend tapping off our PDN and other steroid-sparing agents within 2 to 3 months. There are different ways to do that. So usually we do it after 2 months, we try to get rid of this. And this is the whole scheme I just introduced to you, and I just summarize it again a little bit. So we have to monitor those patients. If the patient's infrequency, everything is fine. If they are frequent or steroid dependent, then you have to check, is there toxicity, is there good adherence? Patients have to be monitored. If the patients go into sustained remission, then it's fine. If they are frequent relapses and are not controlling therapy, then we have to introduce a steroid-sparing agent. This is also the case in patients with steroid-dependent nephrotic syndrome. Of course, you have to discuss the optimal approach. I just told you table number 5. And then later on, you have to see what's going on. If the patient is controlling therapy, you should always try to get rid of all this medication and prioritize based on the toxicity profile. If the patient is not controlling therapy, you may consider rituximab, especially in non-adherent patients. And if it doesn't work at all, consider enrollment in available clinical trials. And there was a long discussion if we could give some recommendation, because some people combine several steroid-sparing agents. We may work in some patients, but we felt there's no evidence to write down a recommendation for this in this guideline. So if you get a call from a colleague, you may give an advice, but we don't want to write this down in the guideline. So, and I think I only got 1 minute, and I will move forward. So with the management of edema, it mainly depends if there's intravascular volume contracted. So if there's prolonged capillary refill time, for example, and the patient has low blood pressure, then patients may require albumin infusions. If the patients have normal blood pressure but intravascular volume contracted, then we go for 20% albumin. If the volume is restored and the patient is having urine, then we may add this furosemide. If patients have severe edema, the primary approach is sodium restriction combined with fluid restriction, and you may discuss to give him albumin and diuretics, but only albumin if the patient has really severe edema. Otherwise, we just go for sodium restriction. And the guideline has 43 patients. There's a lot of other stuff given the guideline with supplementary material, and there will be translations for and education material for patients and families will be provided soon in 20 languages. This will all be available on the Ipna webpage. And I want to thank you, all fantastic colleagues and also patient representatives who contributed to this guideline. This was really a pleasure. We had, I think, 170 Zoom meetings altogether with all subgroups in 2 years. These are the name of all the people. We also have an external expert groups with endocrinologists, general pediatrician, transition specialists, and dietitians, and also many patient representatives who looked at the guideline. And then, of course, the external voting panel, the independent, who really gave us a frank feedback, because sometimes we were not recognizing the real problem, and then brought us back, well, please comment on that. This may be misleading, and then we had to redo it again. And I would like to let you know that we have next year's the next ESPN meeting, which will be a hybrid meeting. It's very interesting, and it's very attractive for many reasons. And we will have now a new thing. We will have reduced registrations fee for participants for middle, low, and very low income countries. For example, low and very low income countries will just be €40, which is equivalent to $40. So I hopefully will see you there in this nice city. It will be a great event. And thank you very much for your attention.
Thank you so much, Dieter, for this excellent and concise talk on the guidelines for nephrotic syndrome. And I just want to start by asking about the definition of nephrotic syndrome, because I realize it's a bit different from that was listed like 10 years ago in the KDIGO guidelines, such that now the patients with nephrotic range proteinuria with either hypoalbuminemia or edema would already be considered as nephrotic syndrome. But what concerns me is there may be patients who have nephrotic range proteinuria with hypoalbuminemia, but not actually edema. So this patient may actually have other conditions, say genetic podocytopathy. So is there any reason behind for the change of the definition?
Yes, it's all the availability, you know, the albumin story, and there's also the cutoff 30 or 25. And the other thing is the degree of edema depends on many things. It depends how long the disease is going on, and especially some young children don't drink so much. And we have sometimes children with relapse who don't have really edema. It takes a long time. So, and if the patient has a large proteinuria and hypoalbuminemia, it's nephrotic syndrome. It's straightforward. I must admit, the art of medicine cannot be replaced by a guideline. Everyone needs a thorough training in a good center to become a pediatric nephrologist and can use this guideline in the background to guide therapy. But to look at the patient, you know, you smell it, you go in the room, there's some funny thing, there's a rush there, the patient has a funny face, it smells like syndromic, then you go forward. And we just try our very best to write this down in simple words to guide people. So this is not a law.
Absolutely. And I have a
also
follow-up.
work all over the world. That's also the challenge. In Germany, we have a little bit different guideline, but it works in Germany, but this would not work all over the world. It doesn't make sense. That's why we did the global guideline. And then, of course, we always said in your own country, you can take the Ipna guideline as a starting point and say, well, in our setting, we have genetics not available, so we will go there. Or we have available, we go there. We don't have cyclophosphamide available. We don't have this drug. And then you can redraw the guideline, tailor it to your country as a starting point.
Yes. And another question is regarding the optimal regimen for the use of rituximab, because I can see that in the recommendation now it's like 1 to 4 infusions. I think is a forever controversy. I just want to see how the expert panel would advise on that.
So there's no evidence that you need more than 1. There's no evidence that you need 4, and every center does a little bit different. So our protocol in our local center is to give 2 shots, and then we, after 1 month, the second shot. That's what we give here. But there are many children who do fine with 1 shot, and I think I would also a little bit. It's a little bit on the parents. I just had the same this conversation today on the ward, where the parents were very, very hesitating with the drug. I told them 10 up to 40%. You know, the Jason paper from which just came out shows 40% hypogammaglobulinemia, and then the parents say, "Oh, I'm totally afraid." So, well, we just give 1 shot, and then we see what's going on. On the other hand, if I have a patient who is already on high-dose cyclosporine and has relapse, then I would say to the parents, well, let's give him at least 2 shots. I think 1 shot will not do the job. And then you can see the B cells in the blood. You know, it's dependent a little bit. If you have available the B cell measurement, then you can just check the B cells. And it depends a little on the setting. So that's, yeah, it's
more than just science.
How do you do that? Again, how do you do that? Maybe I ask you, how do you do that?
You mean in rituximab, the regimen we use?
Yeah.
Well, in Hong Kong, we give 2 infusions most of the time, and you know, some patients they require repeated infusions, and just to work very well with a single shot, and they can have a long time of remission. But we do have some problem with the cost before the availability of biosimilar. So at some point, we were a bit restricted also by the cost of the medication. But now with the biosimilar, it works much better, and we can have a more individualized approach according to the physician and also the family perception.
And there will be, I think, hopefully, and sometimes the type 2 CD20 depleting therapy, the oponitumab, which is seems to be much more effective, and then you just need a few shots, and then you have 1 year time to look what's happening.
We don't have that in Hong Kong yet, but you know,
yeah, I think
in Paris, I think they are having a very good cohort. So something may come up in the next few months, hopefully.
Excellent.
Okay, we have another important questions from Charge. So he's asking for an obese child. Would you suggest to use the ideal body weight or the actual body weight for drug dosing?
Ideal body weight.
Extend on that, whether we should use a kilogram base or body surface area base for the drug dosing of
I would, if that's a very good question, and there are parts of the world where children or adolescents are really extremely obese, and if you calculate then by milligram per kilogram, then will you absolutely toxify them. So I would rather go to the lean body mass and rather go for the body surface area, because milligram per kilogram is much more than rather body surface area and rather lean body mass. So don't adjust this to 120 kilogram. But then again, we have the maximum dose of 60 milligram. You are safe. We already we already appreciated that. I'm happy. So the maximum dose is still 60 milligram. In Germany, it's 80 milligram, but we agreed here on 60 milligram, so we are safe. So the obesity, the extreme obese patients don't have a risk if you follow the guideline.
That's a very good safeguard. And from the same person, he's asking how many doses of rituximab can be repeated for a patient with nephrotic syndrome in her or his lifetime.
We don't know. Unexpectedly, it's well tolerated, and in the Jason paper just came out a few months from Keltulis. I think patients had up to 12 rituximab doses, and this was well tolerated. There's no reason to withhold it in patients who need treatment. And the other thing, in those patients who have really years and years to go and to transition, it's very nice to have rituximab, because the side effect profile in a patient who need many, many years of treatment for rituximab seems to be better compared, for example, to calcineurin inhibitors, because they all kill the kidney over time.
Well, we have quite a bit of questions on rituximab. I think this is really something we want to know more as a pediatric nephrologist. And the other person is Min Hua Zhang. He asked about what about to combine steroid-sparing agents together with rituximab. So I think he's referring to the use of concomitant immunosuppression during rituximab.
I think so, you can call me, you can call every colleague from the call group, or Eugen Chan, who can give you advice, but I will not give advice on that in a webinar, because it's very tricky, and then people 100% trust what I recommend, but it's in the end not a recommendation because it's not evidence-based. I can tell you what I do if I'm desperate, and we all do more or less the same if we're desperate, but I think we don't want to comment that on the webinar. I'm afraid I think it would not be wise to do that.
Thank you. And I try to ask something other than rituximab. Ipna, he asked about in case of a relapse, and if we have already edema and also hypoalbuminemia with a test of proteinuria confirmed, do we have to wait 3 consecutive days before we start treatment?
I think with rituximab, the only thing is it must not be lost in the urine. So if the patient is just the first day not in remission with the proteinuria, not in complete remission, but in remission with respect to proteinuria one day, then you can give rituximab. And you should always try to get the patients into remission. And if there's no large proteinuria, just a little bit of protein in the urine, then you can give rituximab.
Yeah, I'm sorry for the confusion. I think he's trying to ask if we need to wait for 3 days before we start.
Physiologically, if you have a patient not losing protein anyway, then you can give rituximab, because then it works. The thing is, withholding rituximab is only because it gets lost in the urine. And if the patient has in the morning negative urine dipsticks, then you can give it, because it's just no protein in the urine. Just give rituximab. I would not wait 2 other days.
Thank you.
You're welcome.
Well, there is a question on cyclophosphamide. The guidelines suggest to use oral cyclophosphamide for frequency relapsing nephrotic syndrome. And I would like to ask if this means only oral route is suggested. Would you use or recommend the use of intravenous route for FRNS?
It's in the guideline. Usually we say we give it orally, but in patients who are, for example, not adherent, we recommend switching to IV, and I think it was 6 times monthly. It was in the slides. Okay, you can do that, and you can. The only thing is if you give it intravenously, it costs some money and it takes some time. But anyway, if you don't have another drugs available and the patient is not non-adherent, then it may be a very good way to treat the patient.
Mhm. So there is another question, is back to rituximab. It asks about when should we consider a redosing? Should we redose it when there is a B cell recurrence or repletion, or we have other considerations?
It depends a little bit on the history of the patient. If you have a patient with really lots of relapses, I would be very, very cautious when the B cells are creeping up, and would then repeat rituximab, because we know what will happen. And it was also noticed in the trials that if the B cells recover in the blood, then we know that the system is just getting upregulated. And in the patient with lots of relapses, you want to avoid this. You want to avoid that he needs additional prednisolone exposure and those things. In these patients, I would regularly monitor it, and usually every 3 months or something. And if you see they are creeping up, I would give a next shot. However, you have to discuss this with the family. If there's already a 1 year no relapse and the patient's doing fine, there's a, well, let's take this risk. We don't give rituximab again, but make close monitoring of urinary dipstick. So I'm in favor to give a next shot, but I know that at some stage you have to stop it.
Yes, yeah. So there was some question, because I think in the guideline it mentioned rituximab appeared to be safer if the children is older than 7 to 9 years. So there's a question from Iman asking what would be the least age we can use, that we can comfortably use.
I'm not quite sure if what was the youngest age, but I think after 1 year of age you can use it. It's the side effect profile is a little bit worse in the younger children, and also a little bit the efficacy. So I think if the patients have already is not controlled therapy with a steroid-sparing drug or has side effects, and you really prove that it's not working, I would not hesitate to start rituximab. But we just want to mention that in the younger patient, it's not as effective, and the older, so you may wait a little bit longer in these children before you switch it to rituximab. There's not good evidence around to make a clear recommendation for that. It's just consider it.
Thank you. So there is a question on the use of cotrimoxazole. I think it's as a prophylaxis for PCP. I think that was mentioned in the steroid-resistant nephrotic guideline. That is actually advisable, right?
Yeah, that's an excellent question. I like this question. And I also, today when I was on the ward and the resident asked me, I was thinking, will he ask me this question? And if you have a patient, on many immunosuppressive drugs, then we always do that. For transplant patients, for example, if they have humoral rejection, we always give this. But if a patient had just some low dose exposure of MMF or cyclosporin, then we felt it's not mandatory to give that.
Yeah.
If you have a patient who always had an extreme high drug exposure, has high dose cyclosporin, and is relapsing, we say, well, we have to add something, and we have high dose cyclosporin, and you have to add rituximab, then I would say, well, let's give him 3-month cotrimoxazole prophylaxis, but only in those who have a high exposure. It's not required for every patient. I would make it on a case by case and depending on the exposure. If the profile of the drug exposure gets close to what we do in transplantation, I will always add it. If it's far less, only one drug, rather moderate dosage, I think it's not mandatory.
Thank you. I think The time is almost the end of this talk, but before the end, I would love to ask one more questions. What to do with the COVID vaccinations after the patient is on rituximab or on other immunosuppression? What would you be the recommendation?
So it's clear in the we have a section for that for vaccination. So in general we first started to write down all the COVID vaccination stuff, but then we realized that it's changing every week, and then we say refer to the national standards, and we do not recommend living live vaccinations in patients who are in the first 6 months after rituximab and on high dose MMF or cyclosporine. Otherwise, even live vaccinations are fine.
Thank you so much again, Dieter, for the excellent talk. We have over 150 attendees for this important and interesting webinar. And before the end, I would also love to promote the upcoming Sister Center Grand Round on the 6th of December, and also the ASPN John Ipna organized Global Health Symposium in February. So please stay tuned in the website, and we are going to have this presentation made available on the Ipna webpage as soon as possible as well. So thanks so much again, Dieter. See you.
Bye-bye. Thank you.
Bye-bye.